A 63-year-old man has 3-month history of painless hematuria. Cystoscopy cystoscopy of the superficial tumor of Cystoscopy shows superficial tumor of the bladder. A biopsy shows well-defined transitional cell carcinoma in situ. Which of the following is the most appropriate treatment?
Ready?
Yes.
Endoscopic resection. Okay. Endoscopic resection is the most appropriate treatment for removal of well-defined transitional cell carcinoma in situ of the bladder. Bladder cancer is the most common malignant tumor of the UTI of the urinary tract, majority which are transitional cell carcinomas. Risk factors include schistosomiasis, chronic cyclophosphamide use, aniline dye exposure, smoking. Patients typically present with painless gross hematuria, although patients may be symptomatic early in the disease process. Diagnosis occurred through cystoscopy and biopsy. Okay. Which is the most sensitive approach for the identification of small precursor tumors. Transitional in situ refers to a lesion of the precursor malignant cells that are confined to the epithelial lining of the bladder and have not yet invaded the subepithelial connective tissue or muscle. Treatment requires resection of the cells with negative margin, which can be achieved through cystoscopic or endoscopic resection. It's not partial cystectomy or total cystectomy are required for treatment of bladder cancer that invades the wall of the urinary bladder. This is typically followed by chemo and or radiation, depending on the extent of the malignancy. Okay,
So
next.
when radiation is done,
I would think maybe if it goes to the back or to the brain, I don't know. I think chemo will
radiation,
be like chemo
radiotherapy.
will
Sorry.
like I think chemo will be if it metastasizes to the liver and things like that. Then radiation is to the brain and the back, the vertebral column. I'm not sure,
Okay.
but I think don't quote me on that. I think. I'm not sure.
Okay, no problem.
Okay.
A 42-year-old woman, a 42-year-old woman has had fatigue, exertional dyspnea, and palpitation for 4 months. She has a history of frequent respiratory infection. Her pulse is 90 regular, blood pressure is 120/80, a prominent right ventricular impulse with a prominent right ventricular impulse, wide fixed splitting S2, systolic wide fixed splitting S2, systolic ejection murmur as heard. An ECG shows incomplete right bundle branch block. An X-ray of the chest shows right ventricular enlargement and prominence of the main pulmonary artery, increased pulmonary artery markings. Which of the following is the most likely diagnosis? Yes,
Ready?
yes. Is it ASD? Okay.
Yes. Okay, I guess I'll read it. ASD defect in the interarterial septum, most common type, ostium secundum defect, although ostium primum are commonly associated with down. That ASD results in the left to right shunt with abnormal flow of blood from the left atrium to the right atrium, resulting in relative volume overload of the right atrium and ventricle. This increased stroke volume of the right ventricle results in delayed closure of the pulmonic valve, which presents as fixed S2 and a low-grade physiologic ejection murmur on cardiac auscultation. The increased right heart volumes also result in terminal right ventricular impulse on physical and may present increased risk of development of bundle branch block. Chest X-ray characteristics demonstrate increased caliber of the main pulmonary artery and increased pulmonary vascular markings. Which one is it? If the ASD remains uncorrected, it can result in development of Eisenmenger secondary to prolonged pulmonary vasculature remodeling, resulting in pulmonary arterial hypertension and shunt reversals leading to cyanosis. Next.
Okay. A 42-year-old woman comes to the physician after finding a mass in her left breast. On self-examination, she has no history of serious illness, takes no medication. Examination of the left breast shows a 3.5 centimeter regular borders in the upper outer quadrant. Aspiration of the mass shows a clear brown fluid. Which of the following is the most likely diagnosis?
Hmm.
Is it fibrocystic?
No, fibrocystic is
It is
a
not
lot.
fibroadenoma, isn't it? It is not like,
Why?
or, or it is fibroadenoma.
I thought fibrocystic was a lot of them, so I don't think it's fibrocystic. I'm
Fibrocystic is
between
lot of
a lot of cyst, fibrocystic disease of the breast. It's like a lot of cyst,
okay,
like bumpy,
lumpy bumpy,
fibro, lumpy, bumpy. Yeah. A fibroadenoma is one, but she's pretty old to have fibroadenoma.
and
So
it is like it is called breast mouse and it is easily movable.
what do you see it? Does it say?
No, that's why
Oh,
in
sorry.
fibroadenoma discussion they actually tell something about the mass,
Yeah, but here it doesn't
like
say that.
and why there is fluid.
Yeah. So do you
Fibroadenoma
think?
isn't it? Is it fluidy collection? Is
Not
fibroadenoma?
really. Not really.
That is one thing I am confused with either fibrocystic disease or galactosile. It is not
That
galactosile.
she's not
Ye-
breastfeeding. Why would it
yes,
be that?
yes. Is it
I'm
Paget's? I don't
the
think
pageant
so.
you should have things on the breast, like the eczema and all these things
Yes,
on the
yes,
breast.
yes. True.
I'm between carcinoma and fibroadenoma.
For carcinoma to be called, it would be irregular borders. The border is regular.
Yeah. Okay, I
So,
will go with fibroadenoma then.
okay, let's see.
And fibroadenoma is just I feel like she's too
Fibroadenoma
old.
is good,
Oh, it's all right.
but
No,
fibrocystic
you
disease
were
is
right. Oh
best.
my God, I'm so sorry. You were right.
No, no, I was very stuck with the fibrocystic disease.
Yeah.
That's why I am talking too
Yeah,
much.
I thought fibrocystis was dumpy bumpy. Anyway, fibrocystic disease occurs most commonly premenopausal. What? There you go. It's premenopausal women over premenopausal over the age of 35 years old. Huh. Patients may present with various sites of breast pain and lumps, various sites of breast pain, which may be bilateral. Fibrocystic disease is characterized by the presence of cysts, stromal fibrosis, hypokine metaplasia, and histology. On exam, the cyst may appear blue dome. This is a benign disease process of the breast and does not convey an increased risk for breast cancer. However, it can result in recurrent breast pain and discomfort. If there is significant pain or discomfort associated with the cyst, aspiration can be performed to attempt to relieve the symptoms. This aspiration can yield fluid that is clear,
Sorry,
milky yellow.
sorry, sorry,
Cyst
sorry.
aspiration can yield fluid that is clear, milky yellow, green, or brown, which are all benign. and typically findings on fibrocystic disease. I didn't know that. Carcinoma encompasses many types of breast cancer, including invasive, lobular, medullary, inflammatory, cystoamyloides. Most common type invasive ductal carcinoma, palpable immobile breast mass, which may demonstrate features such as speculated margin, microcalcification. And fibroadenoma is one of the most common benign breast masses in patients younger than 35. Typically presents as well circumscribed solid mobile mass that demonstrates an increased size in relation to the menstrual cycle. Although in pregnancy, fibroadenomas are not typically cystic. Okay, okay. Next.
So the main take home is like cyst aspiration in the fibrocystic disease. It may be either clear fluid, milky, or yellow green.
Mm-hmm.
Okay. A 27-year. Okay. Which of the following is the most appropriate next step in the management? A 27-year-old man. A 27-year-old man undergoes Roux-en-Y gastric bypass for morbid obesity. He has type 2 diabetes, mellitus, hypertension, and sleep apnea. 12 hours after the operation, he is awake and alert. He is 175 centimeter tall, weight is 139 kg, BMI is 45. His temperature is 38.1 degrees Celsius, pulse 90, respirations at 10 per minute, blood pressure is 145 by 85. Breath sounds are Breath sounds are heard bilaterally with decreased air movement. Breath sounds are heard bilaterally with decreased air movement. ABG, arterial blood gas analysis, 4 liter per minute of oxygen via nasal cannula. pH 7.31, pH 7.31, acidosis, PCO2 55, PO2 64, and bicarbonate is 26. So this respiratory acids. Which of the following is most likely diagnosis?
Ready?
Wait. Breath sounds are hard. Okay.
Okay, so application of CPAP. Application of CPAP is the most appropriate next step in management of this patient hypoxemia, hypoventilation, and respiratory acidosis, which are likely multifactorial on the basis of postoperative pain, sleep apnea, sleep apnea, obesity hypoventilation syndrome. In the postoperative state, patient are at increased risk for poor ventilation and resultant atelectasis. This risk is further pronounced in patients with morbid obesity, decreased mobility, and sleep apnea, and underlying uh, heart disease, lung or heart disease. The patient presents with decreased air movement on lung auscultation, bradypnea, and the arterial blood gas demonstrates hypoxia, hypercapnia, and acute respiratory acidosis. To improve this patient ventilation and oxygenation, postoperative pain should be controlled to reduce ventilation-associated discomfort, and non-invasive positive pressure ventilation such as CPAP should be used to promote oxygenation through resolution of the atelectasis and ventilation to maintain patency of the airway. If the patient remains hypercapnic in spite of pain control and CPAP, bilevel positive BiPAP should be attempted next, which will promote increased manual ventilation by assisting inhalational effort. CPAP may stand the airways open, but if this is not sufficient to promote ventilation, escalation to BiPAP or invasive positive pressure ventilation may be required. It's not switching nasal cannula to face mask will allow for a higher oxygenation delivery to the patient, But this may not improve the patient ventilation as it will not promote airway stenting via continuous positive airway pressure during inhalation and exhalation. And it's not, where was I? Intubation will be an appropriate step in management if non-invasive positive pressure ventilation does not improve the patient respiratory acidosis, blah, blah, blah. Non-invasive positive pressure ventilation should be attempted first unless the patient presents in an altered mental state or coma and is unable to protect the airways. Okay, next.
A 92-year-old woman is brought to the emergency department 6 hours after the sudden onset abdominal pain, distension, and vomiting. She has not passed flatus during this period. She underwent appendectomy 46 years ago. Abdominal examination shows of distension and diffuse tenderness. Bowel sounds are increased. An X-ray of the abdomen is shown. Which of the following is the most likely explanation of these findings?
Ready?
Yes. Is it adhesion?
Yes. Adhesions are most common cause of SBO, small bowel obstruction, in patients with a history of prior intra-abdominal surgery. Obstruction of the small bowel occurs from partial or complete blockage of the small bowel lumen. Typically presents with nausea, vomiting, abdominal pain, abdominal distension. Partial SBO will allow a degree of continued flatus with diminished stooling, and complete will result in obstipation. SBO has many potential causes, although the most common is post-surgical peritoneal adhesion and hernias. Physical exam SBO typically presents with diffuse abdominal tenderness, distension, tympanic percussion, borbic, I don't know, high-pitched hyperactive bowel sounds. Potential complications of SBO include bowel rupture or necrosis, which can result in peritonitis. Abdominal X-rays, if obtained in erect position, demonstrate multiple air fluid levels in the setting of dilated bowel loops. Management, bowel rest, high dehydration, surgical intervention. If the patient has partial obstruction, the patient should be monitored and provided supportive care. The patient demonstrates features concerning of persistent partial or complete obstruction, surgery, laparotomy should be done to alleviate the pain. Okay.
Next. Do you want to read the other options?
No, that's fine. Next.
A 49-year-old man with a type 1 diabetes mellitus remains hospitalized 2 days after admission for management of the gangrene of the second toe of the left foot. He has a peripheral neuropathy, retinopathy, and a stage 3 chronic kidney disease. His pre-admission medications are insulin, valsartan, ramipril, gabapentin, and omeprazole. On admission, IV piperacillin tazobactam was added to the regimen. He is following He is following a constant carbohydrate diet. His temperature is 37.2 degrees Celsius. Pulse 72 per minute or Pulse 72 per minute. Regular blood pressure is 140 by 90. Examination shows dry gangrene over the distal phalanx of the left second toe with minimal residual erythema. Pedal pulses are not palpable. Ankle systolic pressure are greater than 200 mm of mercury bilaterally. Lab study shows hemoglobin A1C 8%, leukocyte 8700, glucose 160, and creatinine 1.8. On duplex ultrasonography of the lower extremity the femoral and the popliteal arteries appear normal. There is occlusion of all three tibial arteries in the proximal calf and reconstitution of the posterior tibial artery just proximal to the ankle. In addition to the continued piperacillin tazobactam therapy and foot care, which of the following is the most appropriate next step in the management?
I have no
There is
idea.
occlusion. It is yeah, peripheral arterial disease, isn't it?
I'm I'm not on this.
Ankle,
Okay, I'm
there is,
understand. Uh-huh.
sorry. Yes, you
Go
say
ahead.
it first.
No, I don't. I don't understand because it says ankle systolic pressure greater than 220. So is that bad or good? Like
Ankle
this
cyst,
one.
ankle systolic, yes, is greater than 220 millimeter of mercury bilaterally.
So that's bad or that's good?
I think that it is good.
Okay, that's good. Okay. And then they say femoral and popliteal are normal.
Yes.
But then they say tibial, so down there, is occluded,
Uh,
proximal to the calf. But then the ankle is good. So I guess we don't have to do amputation because the ankle is kind of
we
good.
we can give supervised exercise to open up
Okay,
the.
you want,
I am thinking about giving exercise first because next step, in this case I think so, like in
I don't
peripheral
know.
arterial disease, uh,
Yeah, usually you start with exercise, but
exercise.
I feel like he has so many things. Okay, maybe I feel like he just has so many. Okay, maybe let's see.
Why creatinine is high?
He has a kidney stage 3 kidney disease
Okay,
because
that's why. So I
of the
am
diabetes.
okay. Let's see what you have chosen, angioplasty.
And I'm not. I'm pretty sure it's not that.
We both are wrong.
It's femoral. Yeah, yeah.
So
So
it
he has too many things going on, so it cannot be like the normal exercise thingy. But
yes,
if it was somebody like a young person, definitely that would be it would be the exercise.
exercise. Yes, true.
Femorotibial bypass grafting. Femorotibial. Okay. Potential treatment for severe peripheral artery disease of the lower extremity. Peripheral artery disease refers to abnormally diminished flow of blood to the extremities secondary to atherosclerotic plaque. This most commonly affect the lower extremity. Risk factor: diabetes, increased age, smoking, dyslipidemia. Patients present initially with intermittent claudication, which results from insufficient blood flow to the muscles during exercise. As the flow of blood becomes progressively diminished with worsening atherosclerosis, it can present as pain at rest and the potential for ischemia and necrosis, gangrene of the extremity. An exam, there are typically diminished or absent pulses in the distribution of the affected artery. If there is critical ischemia of the extremity, gangrene may also happen. Doppler's ultrasound and arteriography, which is catheter-based CT, whatever, of the lower extremity can be performed to evaluate the location and length of the atherosclerotic disease and its impact on lumen diameter and blood flow. Treatment includes instituting exercise programs, silostazole, aspirin, and if severe angioplasty stenting or surgical artery bypass. Amputation may be necessary if the degree of gangrene is significant. The patient presents with intact femoral and popliteal arteries, but occluded calf arteries, although the distal posterior tibial artery demonstrates a constitution. Femorotibial bypass graft replacement will restore blood flow to the distal lower extremity.
Why
It's
it is
not
not D?
it's not percutaneous.
Amputation would not happen because there is no gangrene.
I mean, he has gangrene, but I don't think it's that bad. Percutaneous tibial angioplasty is a potential intervention to improve the lower extremity blood flow through catheter-based whatever stenting. Because of the degree of occlusion in the calf blood vessels, tibial angioplasty may be impossible or impractical. Wait, because of the degree of occlusion in the calf blood vessels, tibial angioplasty may be impossible or impractical. Bypass grafting will provide an easier conduit for restoration of blood flow. Don't understand what
Ah,
that means.
yes, I don't understand.
Below
They
the
told you already that the next option is angioplasty, then the surgery, isn't it? If
yeah,
severe angioplasty stenting or then finally surgery, why?
it says because of the degree of occlusion of the
So how
calf.
we can measure the degree of the occlusion?
Oh no. There is occlusion of all three tibial arteries. Okay, it says three tibial arteries
Okay,
are occluded. So
so
maybe because it's three, so then you have to do three angioplastic,
okay,
three different angioplastics. Whereas if it was one, you just have to do one. But if you do the grafting, you kind of bypass all the three angioplastics all at once during the surgery.
okay,
You
that
see what I'm
makes
saying?
sense. Yes.
That's, it's not below the knee amputation is not indicated as the patient demonstrates gangrene of only the one toe. Amputation is only indicated in the setting of severe gangrene of the lower extremity or if it's complicated by superinfection or necrotizing fasciitis. Okay, next.
A 72-year-old man is admitted. A 72-year-old man is admitted to the hospital because of hematochezia for 12 hours. He has mild COPD and osteoarthritis. He sustained a myocardial infarction 4 months ago. Medication include propranolol, nitroglycerin. Propranolol and nitroglycerin. His temperature is 36.9 degrees Celsius, pulse 102, blood pressure 144 by 80. Abdominal examination shows no abnormality. Rectal examination shows dark blood and clots. His hematocrit is 32%. His hematocrit is 32%. Bleeding resolves spontaneously 6 hours after admission. Colonoscopy shows a short segment of sigmoid colon. Colonoscopy shows a short segment of sigmoid colon with edema and ulceration and friability, and no other abnormalities are noted. Which of the following is the most likely diagnosis?
Ready?
Okay, ulcerative, is it?
Nope. Ischemic colitis refers to inadequate blood supply to the colon, which can lead to bowel necrosis, loss of immune barriers, and bowel perforation. Ischemic colitis most commonly occurs in the setting of atherosclerosis
He
resulting in
has
plaque rupture.
hypertension. Oh, sorry, he has myocardial infarction.
That was 4 months ago.
Yes, that is the
Um,
culprit.
within a mesenteric plaque rupture within a mesenteric vessel. Systemic hypotension, shock, or emboli such as AFib. Diminished blood flow within a vascular territory results in a specific results if a specific mesenteric artery is occluded or narrow. If in the case of systemic hypotension, blood flow will be reduced within a watershed region. Patients typically present with acute abdominal pain and cramping associated with bloody bowel movement if bowel necrosis has occurred. Imaging may demonstrate thickening of the bowel wall, along with pneumatosis intestinalis and possible portal venous gas and pneumoperitoneum. Mm. Diagnosis ischemic colitis require angiographic evaluation to assess the patency of the mesenteric arteries. Treatment of occlusive lesion includes anticoagulation, thrombectomy, angioplasty, and stenting. Hypoperfusion states require treatment with fluids, blood products, vasopressors. In cases of necrosis and perforation, bowel resection and partial colectomy may be required. Not UC, chronic inflammatory condition within the spectrum of IBD that results in inflammation and ulcers of the colonic mucosa and submucosa, typically beginning with the rectum and advancing proximal symptoms, chronic abdominal pain, weight loss, bloody diarrhea, abdominal bloating, and tenesmus. Okay, next.
A hospitalized 37-year-old woman with type 1 diabetes mellitus with chronic renal failure has the sudden onset shortness of breath. 25 minutes ago, she underwent placed a right subclavian catheter for hemodialysis after several unsuccessful attempts to insert a right jugular venous catheter. Her pulses her pulse is 120 per minute, respirations at 32 per minute, blood pressure 90 by 50 millimeter of mercury. Examination shows no jugular venous distension. Breath sounds are decreased on the right. Heart sounds are normal. Pulse oximetry 4 liter per minute of oxygen via nasal cannula shows oxygen saturation is 65%. Which of the following is the most appropriate next step? Hmm,
Hmm. Ready?
yes.
Oh, it's needle aspiration of the right chest. This is hard. Baby. CMS. Needle aspiration of the right chest is the most common appropriate intervention in the treatment of this patient. Central venous catheter placement, related tension pneumothorax. Oh, so it was PE. Central venous catheter placement related pneumothorax. Pneumothorax results from N entering the interpleural space from either an external central venous catheter placement or stab wound, or internal, like a bronchus rupture bleb or rupture bronchus or bronchopleural fistula. As the air accumulates within the space, the lung parenchyma becomes compressed, resulting in reduced breath sounds, hyperresonance, supercussion, respiratory distress, and in severe cases, tension of the on the mediastinal structure impending venous return. Signs of tension pneumothorax include tachycardia, hypotension, hypoxia, JVD, even if here JVD is not present, and tracheal deviation. In cases of acute tension pneumothorax, evacuating the accumulated air via needle decompression and aspiration permits expansion of the lung and eliminates tension of the great vessels. Needle decompression is followed by tube thoracostomy, which prevents accumulation and promotes repair of the pleural defect. It is not G. Pulmonary angiography constitutes invasive catheter angiographic evaluation of the pulmonary arteries This is no longer necessary for diagnosis of PA given advanced in ventilation perfusion scan and CT pulmonary angiography. Hmm. But it may still be performed if pulmonary embolectomy is required. Not altered ABG analysis is used in a variety of acid-base and respiratory disturbance, allowing for analysis of the patient acid-base status, oxygenation, and ventilation. Will not take priority over emergent needle decompression of the tension pneumothorax. X-ray and CT scan of the chest will demonstrate the laterality and size of the pneumothorax, although the diagnosis of tension pneumothorax should be clinical, as obtained diagnostic imaging will delay emergent management. An echo does not have a defined role in the evaluation of the pneumothorax as it solely evaluates for heart and pericardium. Bedside ultrasound can be used to evaluate for the presence of pneumothorax, although tension pneumothorax is typically a clinical diagnosis because it's an emergency. Okay.
Next. A
Mhm.
62-year-old man comes to the physician because of an year history of pain in the calves and thigh after he walks more than 2 blocks. The pain is relieved uh, for after he rests 5 to 10 minutes. He has smoked 1.5 pack of cigarettes daily for 30 years. His temperature is 37 degrees Celsius, pulse is 75, respiration 16, permanent blood pressure 140/80. Examination shows decreased femoral popliteal pedal pulses bilaterally. Which of the following is the most likely diagnosis?
Hmm. I have no idea on this
We have done a question in the world.
one. With the fact that you remember that, no idea. The fact that you remember that we've done it, okay. Okay. Ready?
There is gut claudication like that.
You think it's Leriche?
Probably
But
because
Leriche wouldn't affect the penis and all these things.
they actually maybe they actually hide those things because that would be easier.
Okay. Okay. Let's see. You are right. Autoileal occlusive disease, Leriche, is autoileal.
Iliac artery is involved, so you have to find anything. I am confused with the iliac artery stenosis and the A. You got my point. Like iliac artery supplies the femoral, then popliteal. Isn't it like that?
Wait, iliac artery, external iliac artery supplies the femoral and
Yes,
internal
yes,
is the thing, so it's not internal. I knew it wasn't a quotation of the outer, it's not fine. But I
yes.
was
Coarctation of the
between,
aorta with hypertension in the upper extremity, hypotension in the lower
yeah, yeah.
extremity.
Okay. Autoileal occlusive syndrome, or Leriche, whatever, is a type of peripheral artery disease resulting from partial or complete occlusion of the infrarenal abdominal aorta and bilateral common um, iliac arteries. This presents as intermittent claudication of the bilateral lower extremities with a characteristic triad of bilateral thigh, buttock claudication, absent reduced femoral cords, impotence. The most common location for occlusive disease is at the aortic bifurcation. Although occlusion can be multifocal and in various distribution, it's associated with large vessel vasculitis like Takayasu, atherosclerosis, increased age, male, sex, smoking, diabetes. Diagnosis occurs to combination of physical exam findings like ankle brachial index, ankle brachial index measurement, CT, MR, angiography. Treatment require revascularization with angioplasty stent placement or vascular bypass. It's not bilateral, where am I? Superficial femoral artery occlusion. Oh, that's femoral. Yeah. Okay. Can occur in the setting of severe atherosclerotic disease, although it will not result in loss of bilateral common femoral pulses. A central lesion resulting in occlusion of the distal aorta and bilateral iliac arteries is a more likely explanation from the patient presentation and exam findings. Okay.
Hello?
Yeah. Ready. Next one. Can you hear me?
Yes, I can hear you.
Okay. Okay. Next.
A 32-year-old, a 32-year-old male firefighter. A 32-year-old male firefighter is brought to the emergency department after being rescued from a burning building. On arrival, he appears anxious. He is hoarse and cough up, coughs up carbonaceous sputum, but his breathing is spontaneous. His temperature is 38 degrees Celsius, pulse is 100 per minute, regular, respiration is 24 per minute, blood pressure is 140 by 95, pulse oximetry show 40% oxygen by face mask and shows an oxygen saturation 94%. Examination shows burn scalp and his examination show burn scalp and facial hair. The lips are not cyanotic or cherry red. There are second degree burns over the face and the neck and third degree burns over the upper extremity. On pulmonary examination, no stridor is heard. The remainder of the examination shows no abnormality. A CT scan of the chest and abdomen shows no body cavity injuries. Direct laryngoscopy shows pharyngeal edema and erythema. Direct laryngoscopy shows pharyngeal edema and erythema in addition to continued supplementation of oxygen by face mask. Which of the following is the most appropriate next to the management of the patient's CRI?
Hmm. Oh my goodness. Ready?
Yes, you highlighted 3 point.
No, I like the D, but I don't know how to. Also, my thing, I cannot remove the other one.
Okay,
It's
okay,
D.
sorry,
I
no
like
problem.
the D.
I'm just making fun.
Transoral endotracheal intubation is the most appropriate next step in management of patient's airway in the setting of acute smoke inhalation. Smoke inhalation injury should be suspected in patients presenting with facial burns, hoarse voice, wheezing, carbonaceous sputum. The inhalation smoke and additional chemicals in the setting of fire presents the risk of injury to the pharyngeal, laryngeal, and tracheal mucosa. Resultant inflammation drives rapid development of mucosal edema, which can cause airway obstruction. Airway obstruction is an immediate life-threatening condition that must be managed at or before the time it occurs. If care, if care is not taken to immediate maintain to immediately maintain an unobstructed path for air to flow into the tracheobronchial 3. Rapid hypoxia hypercapnia, and they can occur if significant airway diminishes. Emergent endotracheal intubation is the best initial step and should be performed immediately to prevent obstruction. It is not, was I confused? Tracheostomy, I guess. May be necessary if securing the airway via laryngoscopy is unsuccessful. However, it should not be attempted until after additional attempt of orotracheal and nasotracheal intubation have failed. I guess that's it.
Okay.
Okay. Let's taking a quick
Yeah.
break before
Yes.
we start. Okay. And then surgery 7.
Yes. Okay.